Hematopoiesis is the formation, production, and maintenance of all blood cells from pluripotent stem cells. Understanding the timeline and location shifts is essential for clinical practice. The process begins early in gestation and moves through 3 distinct sites. From 2 to 3 weeks gestation, the yolk sac produces only red blood cells and macrophages. This tells us other blood cell types aren't essential during early embryonic development. The liver takes over as the predominant site, peaking at 4 to 5 months gestation. From 22 weeks forward, bone marrow becomes the primary site and continues throughout life. This process is regulated by hypoxia, infection, and stress, mechanisms that become crucial when understanding pathological conditions in the NICU. Remember these timelines and transitions, as they directly impact how we interpret laboratory values and clinical presentations in neonates of different gestational ages. Fetal hematopoiesis follows 3 distinct phases. The mesoblastic phase occurs from 3 to 8 weeks gestation, where primitive erythroblasts form in yolk sac blood islands. These produce large, nucleated red blood cells containing embryonic hemoglobin. The hepatic phase spans 6 weeks to 6 months gestation, with the liver becoming predominant by 9 weeks and reaching peak production at 4 to 5 months. The myeloid phase begins after 20 weeks of gestation, with bone marrow taking over by 22 to 24 weeks and continuing throughout life. Notice the overlap between phases. This isn't a clean handoff, but a gradual transition. Understanding these phases helps explain why preterm infants have different hematologic responses, and why extramedullary hematopoiesis can reactivate earlier sites during stress conditions, like severe hemolysis or congenital infections. When the bone marrow becomes overwhelmed or damaged, the body has a remarkable backup plan. It reactivates those fetal hematopoietic sites we just discussed. Extramedullary hematopoiesis occurs during severe stress, particularly with severe hemolysis or congenital infections. The liver, spleen, and even skin can resume blood cell production. The classic clinical sign is the blueberry muffin rash. These purple-blue nodules represent dermal erythropoiesis, essentially blood cell factories in the skin. When you see this rash, immediately think congenital CMV or rubella infection. This isn't just a cosmetic finding. It indicates significant systemic stress and often severe anemia. The skin lesions may fade as the underlying condition resolves, but their presence tells us the infant's hematopoietic system was pushed beyond its normal capacity. Understanding this concept helps explain why some sick neonates can maintain relatively stable blood counts despite ongoing losses. Erythropoietin controls red blood cell production through a sophisticated feedback system that changes after birth. During fetal life, the liver produces EPO, but after delivery, production shifts to the kidneys. EPO responds to tissue hypoxia and anemia. When oxygen delivery drops, EPO levels rise to stimulate more red blood cell production. Certain conditions chronically elevate EPO levels: intrauterine growth restriction, maternal diabetes, pregnancy-induced hypertension, and Down syndrome. These infants often present with polycythemia due to chronic in utero hypoxia. EPO levels become a valuable diagnostic tool when evaluating anemia. High EPO with anemia suggests appropriate bone marrow response to blood loss or hemolysis. Low EPO with anemia might indicate bone marrow suppression or inadequate EPO production. This distinction guides whether we need to support the infant with transfusions or investigate underlying marrow problems. Neonatal red blood cells have distinct characteristics that directly impact clinical care. They're significantly larger than adult cells, with an MCV of 95 to 125 femtoliters, compared to adult values of 80 to 100. This larger size is normal and shouldn't be mistaken for pathology. More importantly, neonatal RBCs have a shorter lifespan, only 60 to 90 days compared to 120 days in adults. This means neonates have higher baseline bilirubin production from normal red cell turnover. At birth, hemoglobin levels are higher, ranging from 14 to 20 grams per deciliter, with fetal hemoglobin predominating. Fetal hemoglobin has a higher oxygen affinity, which was advantageous in the low-oxygen uterine environment, but shifts the oxygen-hemoglobin dissociation curve to the left after birth. Neonatal RBCs are also more susceptible to oxidative stress due to lower antioxidant enzyme levels. These characteristics influence transfusion thresholds, bilirubin management, and interpretation of laboratory values in the clinical setting. Using gestational age-specific reference ranges is essential for accurate clinical assessment. Term infants present with hemoglobin levels of 14 to 20 grams per deciliter and hematocrit values of 42 to 65%. These values decrease with decrease in gestational age. Infants born at 28 to 32 weeks have hemoglobin levels of 13.5 to 14.5 grams per deciliter, while those born before 28 weeks typically range from 11 to 13 grams per deciliter. Understanding these normal variations prevents unnecessary interventions in appropriately developing preterm infants. All neonates experience a physiologic nadir between 8 to 12 weeks of life, as fetal hemoglobin production decreases and adult hemoglobin production hasn't fully compensated. This nadir occurs earlier and is more pronounced in preterm infants. Reticulocyte counts at birth are elevated at 3 to 7%, reflecting active red blood cell production. These values help distinguish between normal physiologic changes and pathologic anemia requiring intervention. When hemoglobin drops below these age-appropriate ranges or falls rapidly, regardless of absolute value, investigation and possible transfusion become necessary. Anemia classification follows 3 distinct pathophysiologic mechanisms that guide diagnostic workup. Decreased red blood cell production includes conditions like Diamond-Blackfan anemia, a rare inherited bone marrow failure syndrome, and acquired causes, such as congenital torch infections that suppress marrow function. These anemias typically present with low reticulocyte counts, indicating inadequate bone marrow response. Increased destruction or hemolysis encompasses immune-mediated causes like ABO incompatibility, membrane defects such as hereditary spherocytosis, and enzyme deficiencies including G6PD deficiency. Hemolytic anemias show elevated reticulocyte counts as the marrow attempts compensation, often accompanied by hyperbilirubinemia. Blood loss anemia can be acute or chronic with different clinical presentations. Understanding these categories helps focus your diagnostic approach. A low reticulocyte count points toward production problems, while elevated reticulocytes suggest hemolysis or blood loss with appropriate marrow response. Anemia of prematurity represents one of the most common hematologic challenges we face in the NICU. This condition is a normocytic, normochromic anemia characterized by inappropriately low erythropoietin levels, a key distinguishing feature. The timing follows a predictable pattern that's inversely proportional to gestational age. While term infants experience their physiologic nadir around 8 to 12 weeks with hemoglobin levels around 11 grams per deciliter, premature infants reach their lowest point much earlier, typically 4 to 6 weeks of life, with significantly lower values. The more premature the infant, the lower and earlier this nadir occurs. The pathophysiology centers on inadequate EPO response. During fetal life, the liver produces erythropoietin, but hepatic oxygen sensors are relatively insensitive to hypoxia. This explains why premature infants cannot mount an appropriate EPO response, despite tissue hypoxia. The transition from hepatic to renal EPO production normally occurs around 40 weeks gestational age, which is why this problem resolves as infants reach term-corrected age. Compounding factors make this anemia more severe than simple EPO deficiency. Premature red blood cells survive only 40 to 60 days, compared to 120 days in adults. Iatrogenic blood loss from frequent laboratory sampling can remove significant blood volumes. Remember, a 1 kilogram infant has only 80 to 90 milliliters total blood volume. Additionally, rapid postnatal growth increases blood volume requirements by 15 to 20 milliliters per week, creating a supply-demand mismatch. This creates the perfect storm: shortened RBC lifespan, inadequate production, ongoing losses, and increasing demands. Understanding this multifactorial pathophysiology helps you recognize why anemia of prematurity is both earlier and more severe than the physiologic anemia of infancy. Anemia of prematurity represents one of the most common hematologic challenges we face in the NICU. This condition is a normocytic, normochromic anemia characterized by inappropriately low erythropoietin levels, a key distinguishing feature. The timing follows a predictable pattern that's inversely proportional to gestational age. While term infants experience their physiologic nadir around 8 to 12 weeks with hemoglobin levels around 11 grams per deciliter, premature infants reach their lowest point much earlier, typically 4 to 6 weeks of life, with significantly lower values. The more premature the infant, the lower and earlier this nadir occurs. The pathophysiology centers on inadequate EPO response. During fetal life, the liver produces erythropoietin, but hepatic oxygen sensors are relatively insensitive to hypoxia. This explains why premature infants cannot mount an appropriate EPO response, despite tissue hypoxia. The transition from hepatic to renal EPO production normally occurs around 40 weeks gestational age, which is why this problem resolves as infants reach term-corrected age. Compounding factors make this anemia more severe than simple EPO deficiency. Premature red blood cells survive only 40 to 60 days, compared to 120 days in adults. Iatrogenic blood loss from frequent laboratory sampling can remove significant blood volumes. Remember, a 1 kilogram infant has only 80 to 90 milliliters total blood volume. Additionally, rapid postnatal growth increases blood volume requirements by 15 to 20 milliliters per week, creating a supply-demand mismatch. This creates the perfect storm: shortened RBC lifespan, inadequate production, ongoing losses, and increasing demands. Understanding this multifactorial pathophysiology helps you recognize why anemia of prematurity is both earlier and more severe than the physiologic anemia of infancy. Managing anemia of prematurity requires a thoughtful balance between conservative measures, pharmacologic intervention, and transfusion support. The foundation starts with blood conservation strategies, minimizing phlebotomy losses through point-of-care testing, implementing delayed cord clamping to increase initial blood volume, and providing comprehensive nutritional support. Adequate protein, folate, and vitamin E are essential cofactors for erythropoiesis. Erythropoietin therapy directly addresses the underlying pathophysiology. Current protocols use 1,000 units per kilogram every 48 hours for 6 doses, then 400 units per kilogram 3 times weekly through 32 weeks post-menstrual age. However, EPO requires adequate substrates. Iron supplementation at 6 to 9 milligrams per kilogram per day is essential, as erythropoiesis rapidly depletes iron stores. Without adequate protein and iron, EPO therapy fails regardless of dosing. Recent studies demonstrate modest reductions in transfusion requirements, with relative risk around 0.66, though benefits are most pronounced in infants over 1,000 grams. Transfusion remains necessary for symptomatic anemia or severe drops in hemoglobin. The decision isn't based on numbers alone, but on clinical assessment, tachycardia, poor feeding tolerance, increased oxygen requirements, or metabolic acidosis indicating inadequate tissue oxygen delivery. For asymptomatic infants, most units use tiered thresholds based on age and respiratory support requirements. The key principle underlying all management strategies is maintaining adequate tissue oxygen delivery while supporting the infant's own erythropoietic capacity. Conservative measures prevent worsening anemia, erythropoietin stimulates production when paired with adequate substrates, and transfusion provides immediate relief when oxygen delivery becomes critically compromised. Understanding how each intervention addresses specific aspects of the pathophysiology helps guide individualized management decisions. Distinguishing acute from chronic blood loss requires understanding their distinct presentations. Acute blood loss presents with classic shock symptoms: pallor, tachycardia, hypotension, and respiratory distress. The key diagnostic pearl is that initial hemoglobin may be normal because hemodilution hasn't occurred yet. The hemoglobin drops over 4 to 12 hours as fluid shifts equilibrate. Common sources include placental abruption, vasa previa, and umbilical cord accidents during delivery. Chronic blood loss presents differently. Infants appear pale but maintain normal vital signs initially because they've had time to compensate. Hemoglobin is low at birth, and the anemia is characteristically microcytic and hypochromic due to iron deficiency from prolonged losses. Fetal-maternal hemorrhage and twin-twin transfusion syndrome are classic causes. The Kleihauer-Bedke test can quantify fetal-maternal hemorrhage by identifying fetal cells in maternal circulation. Recognizing these patterns prevents misdiagnosis and guides appropriate immediate management. A systematic diagnostic approach prevents missing critical information. Start with a complete blood count, including differential and reticulocyte count. This tells you if the bone marrow is responding appropriately. The blood smear provides crucial morphologic clues. Spherocytes suggest hereditary spherocytosis. Schistocytes indicate microangiopathic hemolysis. And nucleated red blood cells may signal extramedullary hematopoiesis. The direct Coombs test identifies immune-mediated hemolysis by detecting antibodies bound to red blood cells. If hemolysis is suspected, obtain bilirubin levels to assess the degree of red cell breakdown. Additional tests depend on clinical presentation. The Kleihar-Bedke test quantifies fetal-maternal hemorrhage. Torch titers identify congenital infections. G6PD screening detects enzyme deficiency, and hemoglobin electrophoresis identifies hemoglobinopathies. This stepwise approach ensures you don't miss treatable causes while avoiding unnecessary testing. Transfusion thresholds depend on the infant's clinical status rather than arbitrary hemoglobin numbers. Infants with severe cardiopulmonary disease require higher hematocrit levels. Transfuse when hematocrit drops below 35% to maintain adequate oxygen delivery. Those with moderate cardiopulmonary disease need transfusion at hematocrit below 30%. Asymptomatic infants can tolerate lower levels, with transfusion indicated when hematocrit falls below 25%. The standard packed red blood cell dose is 10 to 15 milliliters per kilogram, administered over 2 to 4 hours. This typically raises hemoglobin by 2 to 3 grams per deciliter. Always use CMV-negative irradiated and leukoreduced blood products in neonates. CMV-negative prevents viral transmission, irradiation prevents graft versus host disease, and leukoreduction reduces febrile reactions and cytomegalovirus transmission. These specifications aren't optional. They're essential safety measures for our vulnerable patient population. Understanding iron physiology is fundamental to preventing deficiency in our NICU population. The critical concept here is timing. 80% of a term infant's total body iron is acquired during the third trimester. This explains why premature infants face such high risk for iron deficiency. They miss this crucial period of transplacental iron transfer, leaving them with minimal stores at birth. Term infants benefit from nature's perfect timing. Their iron stores accumulated during the third trimester provide sufficient iron for the first 4 to 6 months of life, perfectly synchronized with the introduction of complementary foods. This explains why healthy breastfed term infants don't require immediate supplementation. The American Academy of Pediatrics recommends starting iron at 1 milligram per kilogram per day after 4 months for breastfed infants, continuing until iron-rich complementary foods are established. Preterm infants require a completely different approach. Without adequate third trimester stores, they need 2 milligrams per kilogram per day, beginning at just 1 month of age, continuing through 12 months. This higher dose reflects their greater needs. Not only are they starting with depleted stores, but they're also experiencing rapid catch-up growth that demands increased iron for both erythropoiesis and tissue development. Here's a critical clinical pearl. Breast milk iron has superior bioavailability compared to cow milk, with absorption rates of 50% versus less than 10%. This explains why even though breast milk contains relatively low iron concentrations, breastfed infants rarely develop deficiency when following appropriate supplementation guidelines. The lactoferrin in breast milk enhances iron absorption while preventing bacterial overgrowth. One important exception warrants attention. Infants who've received multiple transfusions may have iron overload risk rather than deficiency. Each transfusion delivers approximately 1 milligram of iron per milliliter of packed cells, potentially leading to accumulation that exceeds the infant's limited excretion capacity. When treating established deficiency, therapeutic dosing increases to 2 to 6 milligrams per kilogram per day of elemental iron. Response should be evident within 1 month with a hemoglobin rise of at least 1 gram per deciliter, confirming the diagnosis while guiding continued therapy. Polycythemia in the neonate is defined as a venous hematocrit greater than 65%. or a hemoglobin level exceeding 22 grams per deciliter. This definition is critical because it's based on venous sampling. Capillary samples can be 20% higher and lead to overdiagnosis. Always confirm suspected polycythemia with a central venous sample to avoid unnecessary interventions. The etiology divides into two major categories: increased erythropoiesis and transfusion causes. Increased erythropoiesis represents the body's compensatory response to chronic intrauterine hypoxia. IUGR and small for gestational age infants experience placental insufficiency, triggering increased EPO production to maximize oxygen carrying capacity. Maternal diabetes creates a unique situation. Fetal hyperinsulinemia increases metabolic demands and oxygen consumption, driving compensatory erythropoiesis. Maternal smoking reduces oxygen delivery through carbon monoxide exposure, while high-altitude pregnancies face ambient hypoxia. Beckwith-Wiedemann syndrome associates with polycythemia through complex mechanisms involving increased EPO production. Transfusion-related causes involve passive transfer of blood volume to the fetus. Delayed cord clamping allows continued placental transfusion. Up to 100 milliliters can transfer if clamping is delayed beyond 60 seconds. In twin-twin transfusion syndrome, the recipient twin receives excessive blood volume from arteriovenous connections in monochorionic placentas. Maternal fetal transfusion, though less common, can occur with placental trauma or abnormalities. Understanding these mechanisms helps predict which infants require screening. The incidence varies from 1 to 5% of term infants, with higher rates in at-risk populations. Remember that polycythemia results from either the body's attempt to compensate for hypoxia or from excessive blood volume transfer. Recognizing the underlying cause guides management decisions. The clinical manifestations of polycythemia reflect impaired organ perfusion from increased blood viscosity. Understanding this pathophysiology helps recognize the constellation of symptoms that demand intervention. The ruddy appearance or plethora results from increased red cell mass in cutaneous vessels. These infants appear deeply red rather than pink, particularly noticeable in the face and extremities. Neurologic symptoms often dominate the presentation. Poor feeding and lethargy occur as cerebral blood flow decreases, affecting the infant's alertness and coordination. The hyperviscous blood moves slowly through cerebral vessels, creating a relative hypoxia despite high oxygen carrying capacity. This explains the paradox of cyanosis in polycythemic infants. Peripheral stasis causes visible cyanosis even with elevated hemoglobin levels. Metabolic complications arise from both increased cellular metabolism and poor perfusion. Hypoglycemia develops because the excessive red cell mass consumes glucose, while decreased perfusion to the pancreas may impair insulin regulation. Hyperbilirubinemia results from increased red cell turnover. Remember, neonatal red cells already have shortened lifespans, and the sheer volume of cells breaking down overwhelms conjugation capacity. Cardiorespiratory symptoms manifest as the heart struggles to pump viscous blood. Respiratory distress syndrome can worsen as pulmonary blood flow decreases. The kidneys are particularly vulnerable. Renal vein thrombosis represents one of the most serious complications, as sluggish flow through renal vessels promotes clot formation. Perhaps most concerning is the thrombocytopenia that frequently accompanies polycythemia. Platelets become trapped in the sluggish microcirculation, creating a consumptive process. This combination of hyperviscosity and low platelets significantly increases thrombosis risk throughout the body. Cerebral, renal, and mesenteric vessels are particularly vulnerable. Recognition of these symptoms prompts timely intervention before irreversible organ damage occurs. Here's a critical concept. Polycythemia and hyperviscosity are not synonymous conditions. While related, understanding their distinction guides appropriate management. Blood viscosity represents the resistance to flow. Think of it like comparing water to honey. As hematocrit rises, viscosity increases, but the relationship isn't linear. The key threshold occurs around 60% hematocrit. Below this level, viscosity increases proportionally with hematocrit, a predictable linear relationship. However, once hematocrit exceeds 60%, viscosity begins rising exponentially. By 65%, blood viscosity has increased dramatically, explaining why we use this threshold to define polycythemia. Beyond 65%, even small increases in hematocrit produce large jumps in viscosity. Here's the clinical challenge. We cannot directly measure whole blood viscosity at the bedside. No point-of-care test exists for viscosity measurement. Instead, we use hematocrit as a surrogate marker, understanding its limitations. This explains a common clinical scenario. Some infants with hematocrit of 68% appear completely asymptomatic, while others with hematocrit of 63% show clear signs of hyperviscosity syndrome. This variability stems from multiple factors affecting viscosity beyond hematocrit alone. Plasma protein concentration, red cell deformability, and temperature all influence blood flow characteristics. Additionally, individual variations in vascular anatomy and organ perfusion create different thresholds for symptom development. The practical implication is profound. Treat the patient, not the number. An asymptomatic infant with hematocrit of 67% may need only observation and hydration, while a symptomatic infant with hematocrit of 64% requires immediate partial exchange transfusion. Clinical judgment based on comprehensive assessment of perfusion and organ function must guide treatment decisions rather than rigid adherence to laboratory values alone. The clinical paradox of hyperviscosity syndrome presents one of the most challenging diagnostic dilemmas in neonatal hematology. Some infants with hematocrit values exceeding 65% demonstrate no clinical symptoms whatsoever, while others with hematocrit below this threshold show clear signs of hyperviscosity. This disconnect between laboratory values and clinical presentation demands we understand the underlying pathophysiology. Hyperviscosity fundamentally represents impaired blood flow through the microvasculature. As blood viscosity increases, flow decreases exponentially in small vessels. Picture trying to push honey through a narrow straw compared to water. The increased resistance dramatically reduces flow rate. In the microcirculation, this creates sludging where red cells move slowly or even stagnate in capillary beds. The result is tissue hypoxia despite high oxygen carrying capacity. A physiologic paradox where abundant hemoglobin cannot deliver its oxygen payload due to impaired circulation. Multiple factors beyond hematocrit influence whether an infant develops symptoms. Plasma protein concentration, particularly fibrinogen levels, significantly affects viscosity. Dehydration concentrates both cells and proteins, worsening viscosity at any given hematocrit. Temperature plays a role. Hypothermia increases blood viscosity, explaining why cold stress can precipitate symptoms. Individual variations in microvascular anatomy, cardiac output, and compensatory mechanisms create different thresholds for symptom development. The management principle emerges clearly from this understanding. Treat symptoms, not numbers. An infant with hematocrit of 68% who feeds vigorously, maintains normal perfusion, and shows no metabolic derangements needs only careful observation. Conversely, an infant with hematocrit of 63% demonstrating poor feeding, lethargy, and metabolic acidosis requires immediate intervention. Clinical assessment trumps laboratory values because symptoms indicate actual tissue compromise rather than theoretical risk based on viscosity calculations. Management of polycythemia requires a stepwise approach based on both hematocrit values and clinical presentation. The threshold for intervention reflects our understanding of viscosity physiology and the risk-benefit ratio of treatment options. For asymptomatic infants with hematocrit between 65 and 70%, conservative management suffices. Ensure adequate hydration through early feeding or intravenous fluids at 100 milliliters per kilogram per day. This approach recognizes that mild polycythemia often resolves spontaneously as the infant transitions to extrauterine life. Serial hematocrit monitoring every 4 to 6 hours tracks the trend. Many infants show spontaneous improvement as plasma volume expands. Symptomatic infants, or those with hematocrit exceeding 70%, require partial exchange transfusion. The goal is reducing blood viscosity while maintaining adequate oxygen carrying capacity. The exchange volume calculation follows a specific formula. Multiply blood volume by the difference between observed and desired hematocrit, then divide by observed hematocrit. For a 3 kg infant with hematocrit of 75%, targeting 55%, blood volume equals 300 milliliters. So exchange volume equals 300 times 20 divided by 75, or 80 milliliters. Critical technical details ensure procedural safety. Use normal saline exclusively as the replacement fluid, never albumin. Studies demonstrate crystalloid solutions achieve equivalent viscosity reduction without the infection risk or cost of colloid products. The historical use of plasma led to increased necrotizing enterocolitis risk, reinforcing the superiority of saline. Target hematocrit between 50 and 55% provides optimal balance between viscosity reduction and maintaining oxygen delivery capacity. Post-procedure monitoring addresses predictable complications. Glucose levels require frequent checking, as the procedure removes glucose-consuming red cells while diluting plasma glucose concentration. Platelet counts often drop due to consumption in the exchange apparatus and dilution. Bilirubin levels may paradoxically increase as improved perfusion mobilizes tissue stores. These anticipated changes guide supportive care in the hours following exchange transfusion, ensuring the viscosity reduction translates to improved clinical status. Delayed cord clamping represents a simple yet powerful intervention that harnesses the natural physiology of placental transfusion. The definition is straightforward. Wait 30 to 90 seconds before clamping the umbilical cord, allowing continued blood flow from the placenta to the newborn. This brief delay capitalizes on the fact that at birth, approximately 100 milliliters of blood, representing 30% of the infant's total blood volume, remains within the placental circulation. The physiology of placental transfusion follows a predictable timeline. Within the first 15 seconds after birth, approximately 25% of placental blood transfers to the infant. By 30 seconds, this increases to 50% transfer. The umbilical vein remains patent longer than the umbilical arteries, creating a one-way flow that naturally augments the newborn's blood volume. Gravity assists this process when the infant is positioned below the placental level, though some transfer occurs regardless of positioning. Understanding the mechanism helps explain the timing recommendations. The American College of Obstetricians and Gynecologists recommends delaying cord clamping for 30 to 60 seconds in all vigorous infants. This timing balances maximal benefit with practical considerations. Most placental transfusion occurs within the first minute, with diminishing returns beyond 60 seconds. The 30-second minimum ensures meaningful blood volume transfer while accommodating the clinical workflow of delivery room management. The volume transferred during delayed cord clamping has profound implications. That additional 100 milliliters contains not just volume, but approximately 50 milligrams of iron, enough to prevent deficiency for months. For a 3 kg infant, this represents a 30% increase in circulating blood volume, providing cardiovascular stability during the critical transition to extrauterine life. This physiologic autotransfusion evolved over millennia as the natural conclusion to mammalian birth, only recently interrupted by immediate clamping practices. The benefits of delayed cord clamping divide into distinct categories based on the infant's gestational age, with particularly compelling advantages for preterm infants. The hematologic benefits begin immediately. Hematocrit increases by approximately 3% through placental transfusion. This translates directly to reduced transfusion requirements, with studies demonstrating a 10% reduction in red blood cell transfusions. For term infants, the iron transferred during delayed clamping provides stores lasting 12 months, effectively preventing iron deficiency anemia throughout the critical first year of brain development. Preterm infants experience even more dramatic benefits. The reduction in intraventricular hemorrhage, 41% in meta-analyses, likely results from improved cardiovascular stability. The additional blood volume helps maintain cerebroperfusion pressure during the vulnerable transition period. Similarly, necrotizing enterocolitis shows a 38% reduction. possibly due to better mesenteric perfusion and the immunologic factors transferred in placental blood. Higher blood pressure at admission reflects improved intravascular volume status, reducing the need for cardiovascular support. The mechanism underlying these benefits extends beyond simple volume expansion. Placental blood contains high concentrations of stem cells, immunoglobulins, and clotting factors. The additional red cell mass improves oxygen delivery during the adaptation to air breathing. The transferred iron supports not just erythropoiesis, but also brain development, as iron serves as a critical cofactor for neurotransmitter synthesis and myelination. However, one critical caution must guide practice. Cord milking is contraindicated in infants less than 28 weeks gestation. Recent studies demonstrate increased severe intraventricular hemorrhage risk with milking in extremely preterm infants. The rapid volume shifts during milking may overwhelm the fragile germinal matrix vasculature. For these most vulnerable infants, gentle delayed clamping without manipulation provides benefits while avoiding the risks associated with more aggressive placental transfusion techniques. This exemplifies how understanding pathophysiology guides safe implementation of beneficial practices.